Hello, it is Wednesday. Welcome back. We are continuing our theme this week of health and the healthcare system. It is the latter piece that I want to address in detail today, healthcare. Today's lesson is dedicated to one simple yet outrageously important question. Why does the United States spend so much on healthcare, such an outrageous amount of money on healthcare, when the rest of the world just doesn't? This is a piece of American exceptionalism that I am not proud of in the slightest. So that's what I want to answer today. What is behind the amount of money that is spent on American healthcare? Okay. Now, the background to this was already established on Monday, where I went over life expectancy, the effect of inequality, the effect of the social determinants of health, and how that plays out in a variety of situations and settings. Now, regardless of what your risk factors are genetically, and regardless of what your social determinants of health are locally, every single one of us is going to need healthcare at some point. Every single one of us. And you can't say that about really about many other institutions. Not all of us are going to work in the same sector. Not all of us are even going to work throughout the majority of our lives. Not all of us are going to get married. Not all of us are going to have children. Not all of us are, not everybody in the country goes to college. But every single one of us is going to need to receive healthcare treatment at some point. Okay. So in the way of announcements, I will first remind you that your final reaction paper is due coming up on Friday. Okay, so please make sure that's in by 9:15. It references the article in Paying Till It Hurts and the documentary that I assigned in Sickness and in Health. Please feel free to reach out if there are any questions or concerns about your ability to succeed on that assignment. Okay, let's get to that question because this is something I'm very personally interested in. Let's start with the concept of universal healthcare. Universal healthcare is the idea that you are going to have an extraordinarily high proportion of your country or of your society with access to healthcare. And that typically in most industrialized democracies takes the form of health insurance. Okay. Here's what I want you to know. The United States is the only developed country. It's the only high income country that lacks universal healthcare. If you want to live in a country that gives you something approximating a high income or a first world living experience, a high income living standard, and doesn't have universal health care, your options are either Turkey or South Africa. And look, no disrespect to the Turks or the South Africans, but people are not exactly banging down the door of those embassies trying to get into those countries. So that pretty much leaves us when you compare us to our friends in Australia, our friends in our friendly northern neighbors in Canada, Western Europeans, even many countries in Latin America, they have achieved universal health care. Okay. And as I said the last time we met, the United States spends more on healthcare. We spend more money on this than any other country in the world. And it is not just because we are, by population count, the third largest, one of the largest countries in the world, the third largest behind only India and China. No, we spend a lot. We spend an insane amount more. And because again, it's like it may make sense that we spend more because of our population size. No, that's not what explains it, because we're spending more per capita, per individual. And look, not to brag, we are slightly wealthier than many other countries. So maybe it makes sense if we're getting better outcomes for this. If we spent a lot but got pretty good quality healthcare, then maybe this is something I would be willing to accept. However, we don't just spend a little more. We spend a shit ton more than anybody else in the world on this stuff. It's $2.5 trillion every year is spent on healthcare. Price that out, it's about 18% of GDP on healthcare. You can see where the US sits here in, this is percentage of GDP. It's a way to normalize for the size of the economy. It's a way to control for the size of the population. And you can see how much higher that is than the second highest country, the Netherlands, and then France, Germany, Denmark, Canada, Switzerland, Austria, Belgium, New Zealand, Portugal, Sweden, the UK, Iceland, Greece, Norway, Ireland, and all the way down to the OECD average of 9.5%. So we're spending almost double what the average OECD expenditure is. And we're doing this for a system that is ranked 37th globally. I know I said this the last time that we met, but we are simply not achieving the outcomes that this level of money spent should be giving you. We're as I said on Monday, we're 33rd in life expectancy. We are 36th in infant mortality. We are 46th in maternal mortality. And the system just is not ranked where you would want it to be. Our system is ranked behind Slovakia. No disrespect to Slovakia, but let me just say that, look, I've been there. I do not see the Slovak Republic as being the comparison that we want to have. Okay, so as a way of further demonstrating this, let's get to some blind resumes. I want you to write down some predictions here. Here I have two anonymous countries ranked on a few measurements of social health. So country A has a GDP person purchasing power of $52,800 per capita. And that country is getting a life expectancy of 79.1, an infant mortality of 5.3, a child mortality, that's death before the age of 5, of 6.9, and an adult male mortality rate of 128 per 100,000 people within the population. What that basically means is each year, for every 100,000 males there are in that country, 128 will die. Then country B, it has a GDP person purchasing power of $10,200, and they get a life expectancy of 79.4. They get an infant mortality of 4.8, child mortality of 6.1, and an adult male mortality rate of 115 per 100K. Now, if those of you who have been paying close attention the last couple minutes and some of the things I've been saying, you have likely ascertained that country A is the United States. The million-dollar question is, what's country B? What country is making 1/5 of the money and is getting comparable and in some cases better health outcomes than we are in the United States of America? I'm going to give you a minute to just think of a guess here. Come up with a country that you think would be 5 times poorer than the United States and maintain similar health status. Give you a minute to think about that. Country B, I shit you not, is Cuba. Okay, this is not meant to criticize the Cubans. It's meant to criticize us. Okay, Cuba's a country that's been under a blockade for decades and decades. Cuba's a country that's been under a dictatorship for a long, long time, and this is what they've been able to produce. We have the same level of health as the Cubans, and that tells me that the system is broken. But why is the system broken? First, let's look at what the system actually is. In the United States, we utilize a private payer system. What that means is we're all responsible for obtaining our own healthcare. However, the primary way in which the majority of people get healthcare is through our job. That's what you're getting here with this 33.4% private health insurance. That combined with a big chunk of this other category, that is the percentage of the people who are probably either getting their health insurance either through a job or through a spouse's job or a parent's job, in your case, for example. And then we have some welfare programs that exist to fill the gaps. So Medicare, you've likely heard of. Medicare is subsidized insurance for either the elderly or the disabled. So by elderly, it's either 65 or 67 to qualify. I forget what it is exactly. And for the disabled, the people who have a physical or a mental disability that would prevent them from getting a job that would allow them to get health insurance or make the money that they would need to buy health insurance. So in the case of like the United States, for what that would look like. I just look at my own family. Well, my grandma is definitely on Medicaid, and I have an uncle. My mom's brother actually is severely mentally disabled, and he is also on Medicare because he is just completely incapable of maintaining a job that would give him health insurance. So we as a society take care of our vulnerable members, or let me just say, we want to take care of vulnerable members who cannot take care of themselves. And the other side of that is Medicaid, which does not have an age requirement, but that's subsidized health insurance for low-income families. Although I will say the threshold in most states for Medicaid is well below the poverty line. So you got to be pretty deeply impoverished in order to qualify for that, okay? So Medicare, you add up the numbers on this, Medicare insures about 58 million people throughout the country, and Medicaid insures 74 million people throughout the country. So when people say we have no public option, like Bernie Sanders is very fond of saying that, when people say we have no public health insurance, it's not exactly true. We have 74 plus 58 million, that's like almost 125 million people, about a third of the country that is on some type of government subsidized and government run and managed healthcare system. That's a big misconception. There's a lot of people on Medicare or on Medicaid that don't know where it's coming from. That's especially common among Medicare. A lot of your grandmas and grandpas don't really know where that's coming from. And there's a belief that it's not a government program. It is, and it's a fairly successful one. It's actually the program, the health insurance marketplace, that always gets the lowest rates on everything, which is not a coincidence. I'll get to that at a later point, though. So that's the United States healthcare system. We are kind of on our own here, and that's very different from how the Germans or the British or the Japanese operate their system. But more on that a little bit later. Here's what I want to do. This is a very poorly understood topic. And in fact, I hear this all the time. I see people going on television. I hear this being debated. And in my opinion, everybody's missing the point of what the real issue is behind the expensive nature of American healthcare. Why is American healthcare so expensive? Let's start with what it's not, okay? Similar to what I did with crime, where I went through many of the hypotheses and showed you some research that either failed to support or in some strong cases disproved that situation and that hypothesis. Here's the first one I always hear, because the region of the world that Americans most commonly compare themselves to is Europe. Like, we always use Europe as kind of a comparison for our own state of society, our own well-being, our own financial situation. And one of the things I always hear is, well, they just pay higher taxes in Europe, and that's why they get cheaper health care. That's why they're getting healthcare for free. Well, for starters, Europeans are not getting anything for free. It's all coming out of their tax burden. And there is a legitimate reason why you might want to do that. Nobody likes paying taxes, but if you were convinced you were getting something really useful and really meaningful to you out of that, you would be willing, and many Europeans are willing, to pay into that. So I always hear like, oh, well, Europeans are getting free college. No, they're not. They're paying taxes into that over their entire life. But by doing that, it gives them the right to draw from that. It keeps college affordable, and then they have the right to go to it very cheaply when it comes time for them to go to college. So it's like, yeah, you have to pay into it over the life course, but you don't have the stress of saving for it or taking out student loans. And it's the same thing with healthcare. It's not that they're getting it for free. It's that they're all paying into it. And when it's your turn to draw from it, when you need to draw from it, kind of like a pension as well is another good example. That's what's known as social insurance. And the Europeans are better at constructing that than we are. However, that's not actually what's going on here. It is true that the European tax burden is higher, but I want to point out something. If we just examine public spending, that's actually just as high in the United States as it is almost anywhere else in the world. Let me go back, actually, just past the Cuban flag, the American flag. What you're seeing here, each country's bar here represents percentage of GDP spent on healthcare. The dark blue part is public money. The light blue part is private money. The United States spends a pretty significant amount publicly. Public meaning tax dollars are what's funding it. But what really makes our country unique is the amount of private dollars that is spent on healthcare. And that is what makes us very unique. We actually publicly are spending a higher percentage of our GDP on healthcare than the Canadians, the British, the Norwegians, the Italians, the Japanese, the Spanish, and the Swiss are. And in return, those people get something called healthcare. How's that for a novel concept? We're spending the same amount as the Canadians are publicly, and we are getting only 37% of our country insured, whereas the Canadians are spending that and insuring 97% of their population. So the issue is not the taxes. It's certainly not the public spending, because we do all that too, but we are doing it far less efficiently. And we are doing it in a way that does not lead to universal healthcare coverage. In fact, it only leads to 37% coverage. Meanwhile, Belgium, Netherlands, Sweden, they're able to spend right about the same that we are publicly. They avoid all that private spending, and they achieve universal healthcare, which we are still pretty far away from being able to achieve. All right, I'll give you a chance to finish up. Keep writing that down. Okay, so it's not taxes. It's not the public spending, because that's equivalent to Canada, the UK, Belgium, and the Netherlands. What about utilization? Maybe we spend more on healthcare because we use it more. Maybe we spend more on healthcare because we need to see the doctor more, or we need to take more drugs, or we need more surgeries. The US actually only leads the world in utilization of two things. We get more MRIs than the rest of the world, and we get more CAT scans than the rest of the world. I have nothing witty to say about that other than just know that that's the thing. However, for everything else, we actually utilize the healthcare system less. It's not that we are using more units of healthcare, so to speak. It's that each of those units of healthcare costs a lot more in the United States than it does in Germany, for example. So if we look at us compared to other nations, let's do our rank and our comparison to the OECD average. We have actually fewer doctors in the country, 2.4 practicing physicians per 1,000, compared to the OECD average of 3.1. So for practicing physicians, we're ranked 26th in the OECD. We are ranked 29th in terms of doctor consultations, 29th in the OECD for how often we actually go to the doctor. We have 3.1 hospital beds per 1,000 compared to 4.9 in the OECD, 131 hospital discharges compared to 155 in the OECD, and our average length of stay in the hospital is actually shorter, 5 days compared to 7.1 days. However, when you consider that you can spend 7 days in a Dutch hospital for the cost of one night in an American hospital, perhaps it makes some sense why we're a little hesitant to go to the doctor. So this is kind of a feedback loop. We go to the doctor less because we know how much it costs. But the outcome of that is we cannot use how often we are going to the doctor as an excuse for the rate of spending that our country displays. One night in a hospital costs $4,200 on average in the United States. It's 5 times what the French are charging, and 7 times what the Dutch are charging, which is just unbelievable when you actually price out what these other countries are paying. And then you see some countries on there, Chile, Argentina. Before you make fun of South America, keep in mind the Chileans and the Argentinians, despite having a fabulous level of economic inequality, do have more efficient healthcare systems than we do. Might not be the best in terms of like the highest quality of care, but it is more efficient for serving the needs of its population. So keeping track of the arguments here, it's not our taxes, and it's definitely not our utilization. That argument is just not supported by data. So maybe it has something to do with the legalistic nature of our society. There is an argument that's especially common among certain lawyers out there that it's due to malpractice insurance. So here's what happens. If you go to the doctor for a surgery and the doctor screws up your surgery, right, lawsuits over that, malpractice, you can essentially sue and get compensated for that. You can get compensated for things like lost earnings. It's actually kind of a dirty thing. Like, it doesn't make anybody feel good to essentially price out how valuable you were as a victim. Life is not an economic equation, but life can sometimes be described with economic equations. And so the idea here is twofold. The first is that the hypothesis goes, we sue the doctor a lot, and that leads the doctor to do two things. First, it leads the doctor to practice what's known as defensive medicine, and that they order a bunch of unnecessary tests and a bunch of unnecessary things in order to essentially cover their asses. So that will allow them to say in any later lawsuit that, like, hey, I cannot be held responsible for what happened because look at all the stuff I assigned. Like, I clearly tried to take care of my patient. Well, you should already know that that's probably not going to be the answer, because I just showed you on the last slide, we're getting things done, and we're going to the doctor a lot less than anybody else. So, it's probably not that. But the other side of it is that there was a belief that because of various pain and suffering payouts, because if you win a malpractice lawsuit, you get paid out for lost earnings and future earnings that you can't get if you're unable to work anymore. But we always hear these stories about people suing the doctor for tens of millions of dollars through pain and suffering. You've caused me emotional trauma, and therefore I want tens of millions of dollars. And the idea is the payouts there, well, the hospital has to be insured against that, and your doctor has to be insured against that. So the prices rise to deal with the fact that hospitals and doctors are all paying themselves much higher malpractice insurance rates, because just like you're insured, and they're insured against your insurance, and the whole thing gets out of control. The answer on this is no, however, for a couple reasons. First, many states have actually passed legislation. It's known as tort reform, and they have passed legislation designed to limit this. So in Texas, Tennessee, a few other places, if you are filing a medical malpractice suit, your payout for the whole pain and suffering type of angle to the lawsuit is actually capped at $250,000. So Texas was the first state to do this, and they cut their healthcare costs by a whopping 0.1%. So they actually addressed this whole thing. And here's the remarkable thing. It actually worked, but it had no effect on healthcare costs. The idea was to limit malpractice payments. This graph shows you that is indeed what happened. The line that you see vertically here, up and down, that's the moment in time in which tort reform was passed. And from that point on, there's been a real decrease in malpractice payments. However, the percentage of people without health insurance, both in Texas and nationally, what you see here, this red line is Texas, the green line is nationally. Not only did that not increase, it did not make people more able to access health insurance, but the total Medicare reimbursements, and we tend to use Medicare here because it's public, and as a result, we know what's getting paid. We have a full set of data to analyze here. That continued to go up as well, both in Texas and nationally. So Texas limited this whole malpractice defensive medicine thing. They continued to be a state with a high level of non-insurance, and a state with a very high level of payouts here, right? Everybody, they continued to pay more than anybody else did or had to. So it's not defensive medicine. What about doctors? I assume there's a few of you. There's always a couple people in my class, my sociology class every year, who are on the medical school track. They want to be a doctor. And people always say something about helping people there. And I'm sure that's very legitimate. But let's not be blind to the fact that we know that doctors make a lot of money. So one of the arguments I've heard frequently is we pay our doctors better than anywhere else in the world. And as a result, we end up with a more expensive healthcare system. But hey, we want to reward doctors we want to have the highest quality health care that we can access. So therefore, that you can't be too careful with your health. So the idea is we pay doctors a lot of money, and therefore we are going to end up with higher prices on the back end of that. No. For starters, European doctors are not working for free, right? Like, yeah, they may make more money here, but what you see on this graph here is like, yeah, the United States does make more money here. Doctors do make more money here, but they make a lot of money in the UK, the Netherlands, Switzerland, Denmark, Canada, France, Australia, and Finland as well. So as a result, I don't see how you can take a small difference in salary and then scale that up to us spending per capita 2 times more than the Canadians and 2.5 times more than the Swedes. And furthermore, if you price this out, like where the money is actually going, when you pay for a doctor's visit, when you pay for an MRI or a CAT scan, only about 8% of every dollar that is spent on healthcare is going to physician compensation. So maybe this helps explain a fraction of the overall pie here, a portion of 8%. That is not going to scale outward to get you to the point where you would see this massive disparity of us outspending the rest of the world and getting shittier outcomes despite that financial outlay. So yeah, the rest is spending. What about the other 92%? It would just be myopic, I think, to pretend that those other 92% is somehow not meaningful, and you can explain everything by by only looking at this 8% side of it. So those of you that want to become doctors, I encourage you to do that. I encourage you to follow your dreams, but do know that it's not your salary that is driving up the price here. You can probably maintain your salary, and we can cut costs dramatically by looking at other things. And I'll get to that towards the end of the class. All right, here's one that I hear frequently. Maybe we're just sicker. Maybe we're just fatter. Maybe we're just lazier. Maybe it's our health status. Maybe we have to spend more. Now, this is perhaps getting somewhere because we do have serious problems accessing preventative care in this country. And we are a little more obese. Like if you look at Europeans, we generally are heavier and more prone to obesity than Europe is. But at the same time, we have fewer smokers and less alcohol abuse. So I honestly think this is probably a wash at the end of the day, at least when you compare us to Europe. But more to the point, despite the fact that, yes, we should be, particularly men, should be accessing preventative care with much more frequently, disease prevalence actually does not correlate with cost. What you're seeing on this graph here, the green portion of this pie chart is the percentage of healthcare spending in the United States that cannot be blamed on disease prevalence. The blue bar is the healthcare spending that can be blamed on disease prevalence. It's a very, very small sliver of the pie. That's not even, look at that. If this was a pizza, that's not even a snack right there. That's barely enough to eat. That's not, and we're close enough to eat if this was a pizza. So, again, yeah, our obesity is a bit of an issue. But also only 8% of Americans smoke. That's 33% in France. That's 38% in Switzerland. And so if I look at the overall system, I just do not see healthcare spending being a result of that. Let's not pretend that other countries don't have health problems as well. Like I already told you about Finland and their drinking problem, the Swiss and their cigarette issues. Healthcare spending is often what you what you're willing to pay, not what you have to pay. And that's important to keep in mind. Now, what about non-insurance? Let's go back to what I started with. This is definitely getting somewhere, but even this is not the primary issue that's driving this. In 2018, we had almost 30 million, 28 million to be exact, or 12.2% of Americans lacked health insurance. If you compare this to what it was in 2010, before the passage of Obamacare, that was 51 million Americans. So this is already going way, way down. And we haven't seen a noticeable decline in healthcare spending, which should probably tell you where this is going. But I do want to flesh out this argument a little bit. Because uninsurance, or non-insurance, I should say, does play a part in explaining this puzzle. So we have 1 out of every 10 people in the country does not have health insurance. And another probably 2 out of 10, so full 30%, I would guess, probably either have no health insurance or really bad health insurance, right? Insurance that doesn't cover anything, which is great if you don't need it. You know, if you're on like a high deductible plan and your plan doesn't cover really much of anything, that's great if you stay healthy. It's not so great if you have to call an ambulance for some reason and all of a sudden that's not covered and you're paying for that out of pocket. So this leads me to the obvious question. If you don't have health insurance, where do those people go when they need care? Well, if I don't have health insurance, I'm definitely not going to the doctor's office for regular checkups. I'm definitely not going for preventative care because that stuff is too expensive for me to pay out of pocket. So the only time I'm getting seen or I'm getting checked out, it might be at a local clinic, but it's much more likely that I only go and get checked out when something really serious has happened. So where do uninsured people go for care? The emergency room. And we're all paying for that. The emergency room, not coincidentally, always charges the highest rates. Look at what hospitals and emergency rooms charge. It's outrageous, okay? Uninsurance, for a variety of reasons, ends up causing about 50,000 unnecessary deaths every single year. But again, I would say the Affordable Care Act is already addressing this. Those deaths are caused because people didn't catch their cancer at stage 1. They caught it at stage 4 because they weren't going for checkups. And so that is definitely a really serious problem. And we should work. Like if you look at Germany, 100% of their population is insured. So this 12.2% doesn't sound like a lot, but that's 20 million. That's a lot of people that are prone to excess death that maybe should not have, that probably should not have gone that way. That being said, this is a very, very serious problem. So the emergency room, essentially knowing that they're the place that a lot of people go to who don't have health insurance, they need to raise their rates to protect against non-payment. And they also raise it because they kind of can, but I'll get to that at a later point. And more importantly, the emergency room, the hospital, has to have insurance against you not paying. So they have to insure against your lack of insurance. And the whole thing gets complicated very, very quickly. There are really serious consequences for this. As of 2009, 67% of all bankruptcies in this country, it wasn't credit card debt, it wasn't defaulting, it wasn't like your business going under or getting laid off. No. 67% of bankruptcies are actually caused by healthcare spending alone. And maybe that's surprising to you, but it shouldn't be. When you consider how much this stuff costs, it's the biggest outlay that we sometimes have to put out there. And this includes many that also have insurance, right? It's not just the non-insured people getting a crazy bill that they can't pay and then going bankrupt. It's a lot of people who also have insurance. I hope you're familiar get familiar with something called the 80-20 split. It's a very common system within the health insurance industry. The 80-20 split basically says that for, once you've, met your deductible, the insurance company will pay 80% of whatever the bill is, and you will pay 20%. And if that's the split, okay, if that's a doctor's office and it's $120 to be seen by the doctor, maybe that's not so bad. What if it's $500,000 of chemotherapy treatment? And yes, it can go that high. How many people have 20% of $500,000 or even $300,000, let's say, laying around that they're able to pay? Not many. And this leads to a tremendous amount of medically induced bankruptcies. And this insurance issue, like the fact that so many of us go to work to get health insurance, That's a primary driver of what's known as job lock. The term job lock is it's a sociological term for people who stay in a job they don't want to be in just because of the benefits. Not even because of the salary, but just because if my children are getting healthcare coverage through my workplace, right, through my insurance policy, I can't leave that job and risk them losing health insurance. So as a result, people stay in jobs they otherwise wouldn't. It like cuts down on very positive risk taking in this society. We have lower rates of business startups and lower rates of entrepreneurship in the United States than Europe does. Despite the fact that Europe is an older population, it's a much less dynamic population and tends to be a less creative population. But they're still much better able to start new jobs because they know, okay, I have this safety net to fall back on. I know even if this doesn't work, I will still be able to get my medical benefits. And don't discount the importance of that the older you get. Once you start a family and your responsibilities really start piling up. No, let's get to the real issue here. So uninsurance is a problem, but here's what I'll just tell you about that. The number of people lacking health insurance has gone way down since Obamacare, and the cost of healthcare has not gone down. It's actually risen. So that is a piece of legislation that has not addressed the root cause of the issue. So let's get to what's really happening here. Now, in reality, we are paying more than other countries for this stuff because we simply pay more than we pay more because we just pay more. And that's a systemic thing. That sounds a little stupid when I put it that way, but let me just walk through these rates with you. How many of you have been to the doctor recently within the last year? What you're seeing here is some country level comparisons. I want you to look at the middle, like the United States, because it's so private when it comes to health insurance, has to be presenting these rates as a scale, essentially. So down here you have the 25th percentile, up here you have the 95th percentile, and in the middle you have the average price. So let's look at that, the middle number on the United States bar. And yes, the United States will be always the most expensive. So if you need to go see the doctor, that's going to cost you on average $95 in the United States. It may run you as high as $200 at the highest level. The Canadians get that for $30. The French get that for $30. The Spanish get that for $11. And this is not some crazy thing. This is not some outrageously unlucky incidents. It's just people need to see the doctor. What if you need a CAT scan on your abdomen? Okay. That in the United States, and I said we have more of this than anywhere else in the world, $630 for a CAT scan. And it could run you well over $1,000. Meanwhile, the British get that for $175. The Canadians get that for $124. And the French get that for $183. So several times less than what the United States has to pay for a CAT scan. Do you need your hip replaced? What about those? Do I have athletes in this class? I think I do. If you play a sport that requires running and or jumping, it is not outrageous to think that you might need your hip might go, that you might need a hip replacement at some point. Very common for especially female athletes, believe it or not. In the United States, that's an average of $40,000 to get a hip replaced. In France, $11,000. In Switzerland, $9,500. In New Zealand, $15,000. And it's not unheard of in the United States for hip replacement to be in excess of $80,000. You got that laying around to go and get that hip replaced? What about an appendectomy? How many of you have ever had your appendix explode? It's always usually one person in the class. An appendectomy, $13,000 and sometimes as high as $30,000. Meanwhile, if your appendix explodes in Switzerland, $4,700. Pardon me. If your appendix explodes in the Netherlands, the Dutch will take care of that for $44,000. So here's my advice. If you're going to have your appendix rupture, go to France to make that happen. Make sure your appendix blows up in the UK or in Spain or in Switzerland as opposed to the United States. How many of you want kids, right? Statistically speaking, many of you in this class will have kids. $9,700 for a normal delivery, just to give birth to a kid. And that can be as high as $15,000. In Switzerland, they're delivering Swiss babies for $4,000, British babies for $2,500, Spanish babies for $2,200. So that's just for a normal delivery if you just want to have kids. Do you need a C-section? Oh, shit. That is really, really going to cost you $15,000 and maybe as high as $25,000, whereas the Dutch will do your C-section for $5,300, and the British or the New Zealanders somewhere between $4,300 and $4,700. Just an aside on the C-section thing here. This is just my typical male ignorance talking here, but I had a very poor understanding of what a C-section actually was for a long time. I always kind of thought it was kind of similar to a Jack in the Box, right? You cut open your abdomen and hey, look, it's a baby. No. I have someone in my family who's had a C-section, and not long ago, I kind of got the play-by-play of how a C-section actually works. It's a very intense medical procedure. It's just doctors have gotten so good at it. We look at it as routine, even though routine in this case involves extracting some of your organs and putting them on the table next to you. The baby shies away from light, so the doctor has to reach in and forcibly extract it. There is a tremendous amount of scraping, and it's very noisy. The whole thing's crazy. What about 1 month of the drug Nexium? This is prescribed to those of you who have issues with heartburn. $202 in the United States for 1 month of Nexium. The French will get that for $30. 1 month of the drug, what else did I say? What was I going to say? 1 month of the drug Lipitor. I know somebody who takes Lipitor for high cholesterol. $124 for that in the United States. In New Zealand, $7. So what is going on here? I have shown you data on how much we are overspending the rest of the world and how little we are getting for that money. So what is happening here? The real concept that is the real thing that's responsible for this, the real culprit, is something called inelastic demand. If you have a marketplace, if you have a situation of inelastic demand, that means that demand for a commodity is not linked to the price of that commodity. What that means in practice is you will pay high prices simply because you have no other choice. So let's look at the other side of this. What's a situation for where you would observe elastic demand? Well, sometimes I go to the subway down the subway in downtown Albion. Sometimes I will go to that restaurant for lunch, right? And they charge what, $5 for a sandwich, $7 if you're not doing the $5 footlong. I'm willing to spend that. I am willing to spend $7 to get lunch at Subway. Now, in a free country, in a free market, Subway can charge whatever they want to for that sandwich, but they really can't, because I'm willing to go spend that $7 for a sandwich. I am not willing to go spend $100 for a Subway sandwich. So while, they could price it however they wanted to, there are limits to what companies can charge for certain things. The limits are what we, the consumer, are willing to pay. So if that's the case, if Subway charges $700 for a sandwich, I'm going to find somewhere else to get my lunch. In the case of the United States healthcare system, the fundamental problem is that demand is inelastic. The fundamental problem is that it's very, very difficult to put a price on the value of not dying. How much is your life worth to you? Really, that I want you to write down a number. How much money would you spend to preserve your life? Because of this situation, people pay a lot of money for healthcare because they need it. And not you need a new Xbox, or I need Ohio State to win a title whenever we get back to college football season, whenever that's allowed to happen. No. You need these things like physical, actual need to stay alive in many cases. cases. So if I tell you, here's a drug that's going to keep you alive, you need to take it every month and it's going to greatly increase your chances of staying alive, of developing a really serious problem. And you can have it for $10 a month. You'll pay that. And then if I say it's $100 a month, you'll probably pay that too. And all of a sudden it's $500 a month. You'll find a way to make that happen. And as a result of this, we end up in a situation where companies, medical healthcare providers, the suppliers of healthcare, charge whatever they think they can get away with. And it turns out they can get away with charging a lot. In the absence of any type of social control on the pricing mechanisms, they don't compete with each other. They just jack up the price and you will continue to pay that. Now, what is up with the rest of the world? Why isn't the rest of the world prone to these issues? Because the Germans need healthcare too. The Swiss need healthcare too. The Japanese need healthcare too. Here's what the rest of the world does. They create a system of much more centralized bargaining. So in Germany, the health minister, the healthcare institution in Germany, like, let's go back to that hip replacement. That's $40,000 in the United States and much cheaper in Germany. The health minister of Germany goes to all the fake hip providers and says, one of you is going to get to put a fake hip in every German. Not every German who needs a fake hip. And your hip, it better be safe and it better be cheap, or else you're not getting this contract. And now, boom, every manufacturer of fake hips in that country is now incentivized to compete with each other. Sometimes you have to insert a little socialism to create the best capitalistic outcomes. And that's what's happened in Germany, right? They spend far less on healthcare and they get far better outcomes. The place, two other examples on this. The place that in the United States that always charges the highest rates is not coincidentally the emergency room. Because think about the inelastic nature of that demand. If you have been shot, if you've been in a terrible car accident, you are not shopping around for prices. You just go into the hospital and you figure out the details later. You go to the hospital that's closest to you and you have absolutely no control of whether they accept your insurance, whether they're in network or out of network, whether they're even going to price what they're going to choose to price you for these things. And so, like, hospitals always are like almost like the canary in the mine here. They are very much the places where you can see the worst outcomes throughout this inelastic demand process. Because once you're in the hospital, once you've already been admitted, are you gonna get up, strip off your hospital gown, and walk a few miles to another hospital to ask them what their prices are for an appendectomy, for example? No. We treat these things first and worry about the price later. And because the demand is so inelastic, that allows the hospitals to charge whatever the fuck they think they can get away with. And as I have said, they can get away with an awful lot here. Okay. And I'm sorry for swearing, but this does make me legitimately angry. In the United States, there is only one system that approximates that centralized bargaining system of what you see Western Europe and East Asia doing, and that's Medicare, which, again, not coincidentally, always gets the lowest rates. Now, other healthcare systems, to wrap this up, they negotiate centrally. The U.S. negotiates individually, and you simply cannot do that effectively on your own behalf. You can't, because you lack the bargaining power. As long as your demand is inelastic, you really can't afford to take it elsewhere. So now, if we think about why has the Affordable Care Act addressed the non-insurance issue, but we're still paying these outrageous rates that the Germans and the Dutch are not, it's because the Affordable Care Act encouraged people to get insurance, but it did not touch this fundamental market inefficiency. And so, yeah, it's one thing to say everybody needs, like, you have this individual mandate, everybody needs to have health insurance, but we've done nothing on the supply side of that for what people are willing to, are charging and people are willing to pay. for these things. And until that fundamental issue is fixed, we will continue to pay more and get worse outcomes. We cannot play both sides against the middle here. That's a losing game. So the last thing that I'm going to say to you about this, we are going to have universal health care, or we are going to have to let people die in the streets. Which society do you want to be a part of? Thank you. Have a great rest of your day, and I'll see you on Friday. Bye-bye.